Welcome to PWS USA webinar series. Tonight's topic is growth hormone therapy, PWS treatments, and supplements presented by Dr. Jennifer Miller. Before we dive into tonight's presentation, let's review some housekeeping notes. Please take a moment to write down the dial-in number and access code for tonight's presentation. Should you become disconnected from the call, the number is 415-655-0060, and the access code is 606-996-035. For those of you using the voice over IP, you may use the option of dialing at any time during the presentation. There is a question segment planned towards the end of the presentation. Please note that the dialog box located at the right of your screen has an option for you to ask questions throughout the presentation so nothing is forgotten. Your line is muted to alleviate distractions, so if you have any difficulties during the presentation or need assistance, please use this question box throughout and I will be happy to provide assistance as best I can. Please do not use the chat box, use the question box. If this dialog box is distracting you, you can click the arrow to minimize it and then click the same arrow to open the box back up and enter questions or comments. Dr. Miller is well known to many of our families. She is a well-respected and much-loved physician who practices at the University of Florida in Gainesville, Florida. I will now turn the presentation over to Dr. Miller.
Thank you. Can you hear me okay? Yes?
Yes.
I'm going to go with you.
Fine. Yes.
Can you hear me okay?
Yes.
Okay. Yes. All right. So tonight we're going to talk about growth hormone, some supplements that people use in Prader-Willi syndrome, and some medications that often people use. So that's that. We're going to start with growth hormone. So at the International Prader-Willi Conference a few weeks ago, I was asked to talk about growth hormone through the ages. And so that's what this is. We're going to talk about infancy through adulthood, even though most of the people on this webinar have children who are young. We will talk briefly about growth hormone use in adults as well. So growth hormone has been shown to improve body composition in individuals with Prader-Willi syndrome. It decreases fat mass and increases muscle mass, as well as improves the respiratory function. Additionally, IQ, or cognitive function, improves with growth hormone therapy, and those with the most severe cognitive delays tend to have the most improvement with growth hormone therapy. So in infants, Erin Carroll's group and Anita Hoken's group showed that growth hormone treatment for infants improved psychomotor development, so this includes gross motor milestones and speech, as well as IQ, or cognitive function. We found in our studies that individuals treated with growth hormone before the age of 1 had less fat mass, a lower BMI, and a higher resting energy expenditure as they got older compared to those who were treated with growth hormone therapy starting after the age of 1. So we took this to indicate that early treatment with growth hormone can help prevent or possibly ameliorate the obesity, some of the obesity associated with Prader-Willi syndrome. Growth hormone also increases blood glucose levels, so it could help with prevention of hypoglycemia or low blood sugars that we see in about 12% of infants with Prader-Willi. These are just the results when we looked at individuals ages 9 to 13 who had received growth hormone either before the age of 1 or after the age of 1. What we saw was that those who had received it before the age of 1 had less body fat and a lower BMI score than those who had received it later, indicating again that it can help with some of the obesity that is common in individuals with Prader-Willi syndrome. Dosing, I get asked about dosing from parents all over the world because everybody, seems to dose a little bit different. The recommendations from Erin Carroll's group are that the dosing be 1 milligram per meter squared per day. Meter squared is the body's surface area, so it's a calculation of weight and height. And what he found was that that seemed to be the best dose for infants. However, some infants needed to go to 1.5 milligrams per meter squared per day to get optimum results. So it all needs to be individualized. Every child is different. Every child needs a different dose. And so we individualize the growth hormone therapy. That's our starting dose, is 1 milligram per meter squared per day, but then you individualize it based on their reaction from their IGF-1 level, which is a surrogate marker for growth hormone, their growth velocity, and their body composition and weight. So not every kid is going to be on the same dose at the same age, and that's because each kid makes their own amount of growth hormone, and we have to then individualize what we give them to compensate for what they are not able to make on their own. Deletion type of Prader-Willi tend to have a higher capacity for growth hormone secretion than those with the uniparental disomy type of Prader-Willi. What this means is that the kids with deletion often need lower doses of growth hormone than those with uniparental disomies because they can make some more on their own. However, the final height and BMI of those with deletion and those with uniparental disomy is essentially the same without growth hormone therapy and even with growth hormone therapy, indicating that the issue may actually be with the utilization of growth hormone, not just how much growth hormone they're able to secrete. So again, this is one of those things that's unique to Prader-Willi syndrome in that we have to actually adjust the dosing based on many parameters, not just looking at one thing, which is the IGF-1 in the blood, because you may need more in order to get the best utilization. So we have to individualize the dosing for each child. So what we know is that around 18 months to 3 years of age, individuals with Prader-Willi syndrome left to their own devices will start to gain weight without a change in calories. And we call this nutritional phase 2A. And what we know is that once that happens, once that weight gain without a change in calories happens, the IGF-1 levels also increase without a change in the growth hormone dose. So this is, right now we don't have any really good markers to tell us when individuals with Prader-Willi syndrome are going through these different nutritional phases, but this is one way we can tell. If the IGF-1 levels all of a sudden increase significantly without us changing the dose, then that's a sign that metabolism is slowing down and that the individual may be entering phase 2A. And then, of course, we adjust the diet to keep the weight gain down. But the important thing to know from this is that several groups have shown that decreasing the growth hormone dose just because of a high IGF-1 level actually can decrease the positive effects of the growth hormone treatment. So you don't want to do it, is the point. So many endocrinologists will lower the dose of growth hormone because they get these high IGF-1 levels. And again, what we and other groups have found is that doing that actually results in less positive effects of the growth hormone treatment. So we encourage people to talk to their physicians about not lowering the dose just because of an IGF-1 level. Data from Anita Hoken's group in the Netherlands shows that, that while that total IGF-1, which is what we can actually measure in a lab, is elevated, the free IGF-1, or what's the biologically active IGF-1, is normal for age. And this is important because when endocrinologists are talking about elevated IGF-1s to parents, they will often say, well, it's a risk for cancer if the IGF-1 level is high. And that is true if the biologically active IGF-1 level is high. But just the total being high doesn't mean anything. And we can't measure that free IGF-1. So we just have to know that most of the time that free IGF-1 is normal. And Anita Hoken's group is working on developing an assay to actually hopefully be able to measure that at some point in time. What we do know about IGF-1 in a positive light is that the higher the IGF-1 level in general, it correlates with self-assessment of quality of life, IQ, and appetite in adults with Prader-Willi syndrome. So our goal is to try to maintain those levels, at the upper part of the normal range to get the most benefit from the growth hormone. But again, if they bump up over the normal range when the metabolism slows down, we don't want you to decrease the dose of growth hormone just because of that factor. Now, if the child had signs of growing too much, their growth rate was really rapid, all of a sudden their hands were growing really quickly, their chins were growing really quickly, that's a different story. So again, this is an individualized thing, but based just on a blood test, we do not want the endocrinologist to lower the growth hormone dose just because of that. So right now we're actually looking back at our family study data that we have to see if we can correlate the IGF-1 levels in infancy and early childhood with the outcomes as these individuals are growing up to be teenagers and adults. So we're trying to look back and see if we push that IGF-1 level to the top part of the normal range when the children were young, what does that do to their cognitive score, body composition, metabolic rate? We don't know the answer yet, but that's one thing we are looking at to see if we can determine that. So the risks, a lot of people, doctors will still talk about that there's a risk of sudden death with growth hormone treatment and Prader-Willi syndrome, and the fact of the matter is there are absolutely no differences in the causes of death between those who are treated with growth hormone versus those who are not treated with growth hormone. The major causes of mortality in Prader-Willi with or without growth hormone are respiratory problems, cardiac arrest, sudden unexplained death, infections, choking, and then ruptured stomach. These deaths peak in newborns and early infants with Prader-Willi syndrome as well as in adults, and the mortality is increased in males with Prader-Willi syndrome, and obesity is a factor in most of those males. So we do need to be cautious. We need to be cautious, especially if it's a male individual, and we need to be cautious, especially during times of respiratory infections. But knowing that information and knowing to be cautious can help you safely continue or start growth hormone therapy in the individual. So in adults, there have been only 8 studies which have evaluated the results of growth hormone treatment. 2 of those have been double-blind placebo-controlled studies, which is the gold standard kind of study. The average dose of growth hormone in adults with Prader-Willi is 0.6 milligrams. There are, as I told you earlier, starting doses for children. For adults, there are not. For adults, you start at a dose and you work with it to keep the normal range. Things like estrogen and testosterone can affect the metabolism of growth hormone. So each individual is different, and you have to adjust the dose of growth hormone in the adults and monitor their levels just like you do in children. The most common side effect of treating adults with growth hormone is swelling of the legs. There's no increased risk of diabetes, but there are some contraindications in adults with Prader-Willi syndrome, and that is morbid obesity or severe untreated obstructive sleep apnea are considered contraindications for growth hormone therapy in this group. In the adults, however, there are still cognitive effects. So even if you don't start growth hormone in infancy, the data shows that there's cognitive benefit to starting growth hormone no matter what age you start it at. And this includes adults. So adults who are started on growth hormone therapy had an improvement in their mental speed and flexibility. They also had gross motor improvement. Their motor performance improved and their stamina improved. When the growth hormone was stopped, the parents documented impairment in physical and social status as well as overall functioning. And on the growth hormone, parents reported improvement in their children's self-control and improvement in their quality of life. So interestingly, much like the kids, with kids we don't have to do a growth hormone stimulation test. In the United States, the diagnosis of Prader-Willi syndrome will get you growth hormone therapy. So you don't have to prove that the individual is truly growth hormone deficient. And in adults, if we could get away without doing a growth hormone stimulation test, what we see is that the positive effects are there no matter what. So even if you make some of your own growth hormone, giving some extra to get your levels in the top part of the normal range actually improves all these different things over not giving it. So there's benefit to growth hormone no matter what, whether you're an infant, a child, or an adult. Like I said, in the United States, it's very difficult to obtain growth hormone after children are done growing, so that's a bone age of greater than 15 years. And you currently have to prove growth hormone deficiency in these individuals by doing what's called a growth hormone stimulation test. And unfortunately, because of the rules of how these tests are interpreted, a very small percentage of adults will actually show growth hormone deficiency on these tests, and that prevents a lot of our adults with Prader-Willi from getting growth hormone therapy. But as someone who treats adults, I can tell you that there is still a huge amount of benefit to them being on growth hormone if we can get it. So many of the parents are actually working with the FDA to try to get these regulations changed so that we could keep individuals on growth hormone for their entire lifetime. That's all I'm going to talk about growth hormone for now. I'm sure people probably have questions, and you can send them to Julie, and I'll be happy to answer them. Also, you're welcome to email them if they're about your own personal child, and I'll be happy to talk to you by email. So now we're going to talk about supplements. The first supplements we're going to talk about are ones that you've probably heard of. They're commonly used in infants with Prader-Willi syndrome, and they're coenzyme Q10 and L-carnitine. Coenzyme Q10 is an antioxidant which supports mitochondrial function. Mitochondria are the energy factories in the muscles. And the evidence anecdotally suggests that coenzyme Q10 actually can improve daytime energy level in infants and children with Prader-Willi syndrome. And what this translates into is actually them being able to stay awake and have a little bit more stamina for sucking and swallowing when being fed orally. So we often try this when people call us from the NICU and say this baby is not eating great, they're falling asleep after 10 cc's of milk. We try coenzyme Q10 to see if it will help that stamina level. Carnitine is another cofactor that works in the mitochondria, in those energy factories in the muscle, and it decreases inflammation and oxidative stress. And again, anecdotally, it's hard to do real studies with supplements because nobody wants to fund them, so the data is all anecdotal with the supplements. But anecdotally, carnitine can improve alertness, strength, and tone. So I encourage parents to talk with their endocrinologists or pediatricians about these two particular supplements when the child is an infant. So if they're not doing well with sucking and swallowing by mouth, you could try these supplements. Or if they have worsening daytime fatigue as they're getting a little bit older and their sleep study is normal, so there's no real explanation, sometimes giving these supplements even to older children can help with energy level and alertness. Vitamins and minerals are important supplements that many families are on. The B vitamins are one of the more common ones. The vitamins B6 and B12 are directly involved in the synthesis of some of the transmitters in the brain, and vitamin B12 in particular frequently improves the functioning of factors related to the frontal lobe. So this is executive functioning or decision making, as well as the language function of those with cognitive disorders. So we often will try vitamin B12 in individuals with Prader-Willi who have speech delay to see if it will help. It does in some, but not in all. And interestingly, adolescents, typical adolescents, not those with Prader-Willi syndrome, but typical adolescents who have low or even borderline low B12 levels actually start to have some cognitive decline. So particularly as individuals with Prader-Willi become adolescents, I would encourage families to look at B12 to make sure that it's maximized so that we don't have any problems with cognition as individuals get older. Most, if not all, but most individuals with Prader-Willi do have high serum levels of the B vitamins. So if you measured a B12 level, it would be sky high. So it's not a good measure of whether or not they actually are using the B12 correctly. And so what we see is that other lab tests that we do can show us that the B12 levels are actually not being, the B12 itself is not being used efficiently and correctly. So even the high levels don't tell you anything. So what we tell people to do is to look at something called a complete blood counter, CBC, and specifically there's this indices on that test called the MCV, which is the size of the red blood cells, and that's a better way to assess whether or not an individual with Prader-Willi needs extra B12. So again, it comes back to the same thing like with the growth hormone and the IGF-1. There are disconnects in individuals with Prader-Willi syndrome, and sometimes you see high levels of things in the blood, but it doesn't actually translate into them using those substances correctly in their body. And so we have to have ways of looking at this around just blood tests. So, you know, it's important as parents. Most doctors don't know this stuff specifically about Prader-Willi, so it's important as parents that you know it so that you can discuss it with your pediatrician or your endocrinologist if you decide that this may be something you want to pursue in terms of supplementation. Vitamin D is another vitamin that we often supplement in Prader-Willi syndrome. It's thought to be involved in the prevention of various aspects of neurodegenerative diseases, but it can be very easily overdosed in Prader-Willi syndrome because it is a fat-soluble vitamin, and most individuals with Prader-Willi syndrome do have a little bit of excess body fat, or a lot, depending on the child. So the first thing you need to do with vitamin D is get the levels checked and then decide if the treatment is necessary with your endocrinologist. This is one that we feel like the actual levels that you measure in the blood do correlate with how you're using the vitamin. So to check a vitamin D level in the blood is fine. Same with iron. Iron is another one that is important for brain because it helps with the oxygen getting to the brain and to produce energy in the brain. Iron deficiency can cause some attention deficit hyperactivity issues, which we can also see commonly in Prader-Willi syndrome. And iron deficiency anemia can be associated with apathy or not wanting to do anything, depression, and fatigue when you're exercising. So iron is an important one to keep an eye on and measure, but it can also be overdosed. So don't just start iron because these things seem like they're really good effects of this supplement. You actually need to check the levels to see if the supplementation is necessary. And when you're on these vitamins, these particular ones, vitamin D and iron, you actually need to have the blood levels monitored to make sure that you're not overdosing. N-acetylcysteine is a really cool supplement we discovered several years ago. It is actually a supplement that works in the brain in what we call the excitatory inhibitory pathways, which are also called the glutaminergic pathways. And this particular supplement, N-acetylcysteine, actually modulates that excitatory inhibitory system and influences the reward reinforcement pathway. So what it means is that this particular supplement actually can decrease some of the reward that one gets from doing a compulsive behavior, as you see in Prader-Willi or autism. So it actually is being tried for psychiatric disorders like schizophrenia and bipolar, but it's also really being found to be useful in psychiatric diseases where there's impulsive or compulsive symptoms like trichotillomania, which is pulling your hair out, nail biting, gambling, substance abuse. We really think that this supplement needs to be further studied to see if you can actually use it to decrease other compulsive behaviors in Prader-Willi syndrome besides just skin picking, which is what we typically use it for. But right now what we're using it for primarily is skin picking. Morris Angulo and I did a study a couple of years ago where we gave N-acetylcysteine supplementation to individuals with Prader-Willi syndrome, and it decreased the skin picking behavior in all of them. It didn't get rid of it in all of them, but it definitely decreased it in all of them. Some of it completely was gone, but in all of them it decreased. This is just a picture of one of the kids. This was his leg in clinic. When I saw him, we put him on N-acetylcysteine, and this is only a week after starting N-acetylcysteine. It was already healed up. He wasn't actually picking anymore. So it's a pretty cool supplement. Lactoferrin is another supplement that parents often will try. Lactoferrin is one of the components of the immune system in the body, and it's part of your innate defense system, particularly at the mucous membrane, so like the nose, the mouth, and it provides antibacterial activity as well as antiviral activity. Lactoferrin also transfers iron into cells and is responsible for controlling the level of free iron in the blood. This is important because if you decide to supplement with lactoferrin to help with preventing your child from getting sick in the winter, for example, because this actually confers some immune system activation, you do have to be very careful about the iron. So we don't want people to start supplementing with iron at the same time they're supplementing with lactoferrin, because the two things do interact, and lactoferrin does increase the levels of iron in the blood. So something you have to just be aware of. But this is an interesting supplement because it does help the immune system. And so for kids who are getting sick a lot during the winter, or who are really hypotonic and can't cough up their secretions when they get a bad chest cold, lactoferrin may actually provide a nice option for parents to try to help keep their children more healthy. Oils are another supplement. It's really a food, but it's also a supplement that we use in individuals with Prader-Willi syndrome. Both fish oil and walnut oil provide essential fatty acids that are necessary for brain myelination. We tend to use fish oil more than walnut oil just because it is more widely available, a little bit less expensive, and contains a couple of these essential fatty acids that help with brain myelination, but you can also use walnut oil. Coconut oil also is something that we use commonly because it reduces the risk for cardiovascular disease. And MCT oil, which is medium chain triglycerides, is another one that we commonly use. MCT is also a pretty interesting supplement in that it actually improves the way that your body burns fat, and it does affect your energy expenditure. So it's a fat that's metabolized in the gut and broken down in the gut in a very different manner than any other fat is, and so it can be used directly in the formation of brain myelination, but it also preserves lean body mass. So it's a really interesting oil that we're using to help with that. Olive oil is still a good oil, it's still a good fat, and we suggest that you vary between walnut oil, coconut oil, MCT oil, olive oil, because we want the children to get a little of each of these, and that way, you're exposing them to all the good things that are in all these different oils. Prebiotics and probiotics are the bacteria and the food for the bacteria that live in the gut. We believe that when individuals with Prader-Willi syndrome enter that phase 2A where their metabolism seems to slow down, that the gut flora, the bacteria that live in the gut, changes when the gut motility slows down. And so we encourage individuals to use probiotics and prebiotics. Probiotics are the actual bacteria which have the health benefit, and prebiotics are the food component that actually feed the probiotics. So these two things together especially can help with bowel movement regularity, increased calcium uptake in the gut. They can help with people feeling more full with what we call energy homeostasis, so the body actually continuing to burn calories at a regular rate rather than slowing down. And in the typical population, there's been some suggestion that prebiotics and probiotics actually can help combat obesity. So that's about the supplements. There are many more supplements, of course. Those are just the most common ones that we use, so I just wanted to discuss those with you. And I'm going to briefly discuss a few medications with you. The most important thing to remember about medications is that you really need to be proactive. Most doctors out there don't know Prader-Willi syndrome very well. So if you've decided that there's something you maybe want to try your child on, you need to find literature about that medication and bring it with you when you go to the doctor, because you're really the expert. Most doctors are not the expert in this syndrome, and you really are. You know your kid, and you'll be able to explain why you want to try it, and if you've got supporting literature to show that it's safe and effective, then that also will help you. You have to remember, however, that some medications can cause significant side effects in individuals with Prader-Willi that they don't cause in other individuals. So things like Ritalin and Adderall are a great example of that, because those are medicines that are used commonly for attention deficit disorder. They tend to work well in the general population. In kids with Prader-Willi, they can cause really severe tics, skin picking, anxiety. They can just bad side effects. So if you're thinking about a medicine, it's really helpful if you consult an expert in Prader-Willi syndrome before you start any new meds, just to be sure that you know what to watch for in terms of side effects. It's also important that you remember that every single medication we use has side effects. And if a doctor blows off your concerns about the fact that your child has Prader-Willi and that they may handle medications differently, you need to be concerned about the doctor and potentially find another doctor, because this is a very valid concern that individuals with Prader-Willi syndrome handle medications differently, and so that they may have these side effects that other people don't have with the medications. So in terms of the endocrine medications, so the medications you see when you need to consider when you see an endocrinologist, thyroid hormone is one that's very commonly abnormal in Prader-Willi syndrome. It's about 20 to 25% of children that will have thyroid hormone deficiency, and about 15% of adults. Testosterone estrogen deficiency, also very common. About 87% of individuals with Prader-Willi syndrome will have deficiencies in these sex steroid hormones, and we have to replace those in some individuals. This is another area where the treatment has to absolutely be individualized to the patient, because these sex hormones can have side effects, of course. You can imagine that testosterone can cause behavioral problems, so we have to individualize whether or not we replace those hormones with each individual patient. And then lastly is cortisol. About 10% of individuals with Prader-Willi syndrome seem to have what we call adrenal insufficiency. Cortisol is one of the stress hormones, and so if you don't make enough of it when you get sick, you can have low blood sugars, low blood pressures, and it can even result in death. So we watch cortisol levels as well and replace them when necessary. I wanted to talk really briefly about stimulants, one of them being Provigil or modafinil. Most typical stimulants cause adverse effects in Prader-Willi, like I mentioned before, like the skin picking and the tics. Provigil and Nuvigil, which is a newer formulation of this medication, both work very well and have been shown to be safe and effective in individuals with Prader-Willi syndrome. They work to help with alertness. They do not help as well if the child truly has attention deficit disorder. But if the child is having trouble staying alert and concentrating in school, these medications can really significantly help. They actually activate the front part of the brain, which is involved in what we call the higher cognitive functioning. So we suspect that they will actually improve IQ because it allows the children to pay more attention in school and actually, integrate what they're learning in school because they're more awake and alert. However, there is a really severe risk with these medications in children, and that is that there can be a fatal rash in individuals under the age of 16. It's not happened in any individuals with Prader-Willi syndrome. This happened in studies of this medication for ADHD several years ago. But parents need to be aware that if you try this medication and your child develops a rash, you have to stop the medication immediately and go right to the doctor, because the rash, if you continue to give the medication, can progress and it becomes like a severe burn and can actually be fatal. I said earlier, with those with a true attention deficit disorder, Provigil or Nuvigil don't work as well as other stimulants do. So you may have to use typical stimulants like you would use in any other kid with attention deficit disorder, like Vyvanse or Concerta or things like that. The most important thing to remember about these stimulants is that if you do need to use them, you want to start really low, like half of the lowest dose, and give each dose about a month, at least a month, before you decide about increasing it or changing it, because you need to see the side effects as well as the beneficial effects of each dose before you decide to change it. You probably may want to discuss with a psychiatrist who knows Prader-Willi and meds may be the best to start with in your particular child, because most psychiatrists, again, like other people, don't know Prader-Willi as well as you do and other experts in the syndrome. There is a new medication that was discussed in the scientific session of the international conference called pitolisant, which is a new stimulant medication, which it needs some additional research in Prader-Willi syndrome, has not been studied in Prader-Willi yet, but presents an interesting option and alternative to Provigil or Nuvigil. So in terms of other meds, there are effective medications for psychiatric issues like anxiety and behavioral problems, but not every medication works for every patient, and some medications have bad enough side effects that you don't want to use them in every patient. And so there is now testing that can be done to determine metabolism of psychiatric meds, and this testing will actually tell you sort of what doses to start with for different meds. So it may say that you're, a very fast metabolizer of, a medication called Zoloft, but a very slow metabolizer of a medication called Celexa. And so you would know that you'd be able to start Zoloft at a normal dose, but with the slower metabolism, you'd have to start the other one at a much lower dose. So it's important information to get if you can get it. Right now it's not covered by insurance companies, unfortunately, but it can be ordered by psychiatrists and done as part of blood work. It's being done actually at LabCorp and other routine laboratory places like that. So you can get it done, but it can be expensive, worth doing before you start psychiatric meds. So now I really wanted to talk very quickly with you guys, especially because most of you have younger children, about some of the research studies that are going on, so that you know the hope that we have for the future of these individuals, because really we have a lot of hope at we're changing the face of this syndrome with the research that's being done. So Loranib was the first drug that we tested in Prader-Willi syndrome. It's the drug from the company called Zafgen, which works to change the way the body packages and metabolizes fat. It actually reduced the production of fatty acid by the liver and actually helped convert the fat that was stored in the body into energy, which was very neat. However, there were extreme safety concerns with this medication. 2 individuals died from blood clots while on this medication, and so the study was discontinued by the FDA a few weeks ago and will not restart, but it was encouraging to see that there was a medication that did help, and so we look forward to using this as a jumping off point for newer medications that are safer and may potentially have benefit as well. Oxytocin is one that many of you have heard about. Oxytocin is another hypothalamic hormone like growth hormone and the sex steroid hormones, and it in Prader-Willi, it was noticed in the 90s that there was a deficit of oxytocin-producing neurons in individuals with Prader-Willi syndrome. This was from autopsy studies of individuals with Prader-Willi who had passed away. Subsequently, Merlin Butler's group noticed that there was a processing defect in making oxytocin in the hypothalamus, and that this low serum oxytocin level actually corresponded with the ghrelin levels being elevated that we saw in individuals with Prader-Willi syndrome. And we know that oxytocin is an important hormone that controls feeding behavior, so the thought was, well, maybe this would work to help individuals with Prader-Willi syndrome if we gave oxytocin back to them, like we give growth hormone back or thyroid hormone back. So the first studies were done by Françoise Muscatelli in France, and she gave the Prader-Willi mice, essentially the MAGEL2 deficient mice, which gives them a Prader-Willi phenotype. She gave them an injection of oxytocin. In those mice, 50% actually typically without oxytocin would die because they wouldn't eat, just like babies with Prader-Willi syndrome. So they had no desire to eat, and you couldn't put an NG tube small enough to get food into a little mouse, and so they would die from starvation. And what she found was that by giving them a single injection of oxytocin, that actually it rescued all of those individuals. So they 100% rescued them. So then Dr. Taubert, who works down the hall from the woman who did this study, actually did a study in both adults and in infants with Prader-Willi syndrome. She gave them a single dose of oxytocin intranasally so that it went from the nose directly up into the brain, and she found that it improved social responsiveness and possibly appetite in adults with Prader-Willi syndrome, and that it improved swallowing and sucking in babies with Prader-Willi syndrome. However, Stuart Einfeld in Australia did a study in adults and adolescents with Prader-Willi syndrome and found no positive effects. And he also actually found that when he tried to increase the dose to see if he could make positive effects, that he got worse effects and had temper tantrums and worsening behaviors with a higher dose. Anita Hoken just published a study this week where she looked at a dose of oxytocin in individuals with Prader-Willi syndrome ages 5 to 18 and found that those that were younger tended to respond better to the oxytocin than those that were older. So all this tells us is that definitely more studies need to be done. There's some positive studies, some negative studies, but we need to do more studies and we need to find the right doses, because clearly just starting at a dose and escalating that dose does not work. It actually can cause more problems. Carbetocin is an oxytocin analog, so it's something that binds to the oxytocin receptors, but it is actually very specifically selective for the oxytocin receptor, so cannot be overdosed. So we think that the oxytocin, those negative effects of the increase in the dose, was because they were overdosed on the oxytocin. This particular drug cannot be overdosed, which is very cool, and so this molecule is actually being investigated for treatment of appetite and behavior such as anxiety and compulsive behavior in individuals with Prader-Willi syndrome. The phase 2 study has been done and the FDA has given permission for a phase 3, so we're hoping that will start at some point in time soon. Diazoxide is another drug that is currently being studied. It's also gone through a phase 2 study and should progress into phase 3 studies soon. This drug actually works by modulating something called a potassium ATP channel, which is a channel that is in a lot of cells, specifically in the leptin receptor, which is in the hypothalamus. And so the idea of diazoxide is that by giving it and activating that leptin receptor channel, that actually you can decrease the hyperphagia, decrease the fat deposition, improve the metabolic rate, and possibly improve the autonomic nervous system. So it's an interesting drug that's being studied, and there was, in the phase 2 study, there was improvement in behaviors during the open label phase of the study, as well as some improvement in appetite, but definitely more improvement in behaviors irregardless of what it did to the appetite. So that will be further studied as well. Another drug that we're studying is a drug called RM493, which now has an official name that I never remember, but it is a melanocortin-4 receptor agonist. And what that means is that what it does is it can activate these receptors which stop people from eating and can prevent obesity. And so, interestingly, when you activate this pathway, you also activate oxytocin expression. So you could possibly get a 2-for-1 with this drug, that you can improve the satiety as well as increase oxytocin and potentially decrease things like anxiety or compulsive behaviors. So this drug actually will decrease the levels of the hunger hormones in individuals, and so the idea is that it potentially could control appetite and improve metabolism in individuals with Prader-Willi syndrome. The phase 2 study is almost done. It will be completed in October, and we'll know whether it works in Prader-Willi syndrome. We're still blinded at this point, but we do know that in individuals with other genetic causes of obesity, like those who are missing this hormone I mentioned up here called POMC, when you give this drug, it actually has a dramatic effect on improving metabolism and decreasing appetite. And they just published this in the New England Journal of Medicine a few weeks ago. The last one is a drug called AZP-531. It is an analog of what we call unacylated ghrelin, and this type of ghrelin is typically a hunger hormone, but this particular type of ghrelin is actually cardioprotective and should decrease hunger a little bit. And so what they found in their phase 2 study was that that when they gave this to 47 patients with Prader-Willi syndrome in a 2-week trial, that there was improvement in the hyperphagia questionnaire, as well as improvement in food seeking and behaviors. So this will also go on to a phase 3 trial to see if this can also help potentially with appetite and metabolism. So it's a lot of drugs that I just mentioned, but I say them all so that you know how much hope there is. There is a lot of things being tried and even more coming. And so this is a really exciting time because we're convinced that we will have an answer soon for the appetite issues in Prader-Willi syndrome, which is really wonderful. So you know, hang in there and know that we are working on it and things are changing, and I would expect a different outcome for younger children versus those who are adults already today. Even though, you know, many of our adults are doing wonderfully, I think that we can expect our children, our younger children, to continue to do even better. And that's all I have.
Oh, Dr. Miller, what a wonderful presentation. For those of you that don't know, I have a 19-year-old niece with the syndrome, and her future is so different from the folks that are 40, and for you young parents, you even have more hope. So that's really wonderful. Let me start with some of the questions that we have, Doctor. The first is,
Okay.
When you say that children treated before 1 have better results, do you mean before 12 months, or does that include infants who start at 13 to 23 months old?
So that's a very good question, and we actually just looked at 12 months and under versus over 12 months. So, but we don't know, as I said, we do know that there are benefits to growth hormone no matter what age you start it. So what we don't know is, does it make a difference to start at 13 months versus 12 months? We don't know the answer to that. So we encourage people to start as soon as they can, but we don't know how much of a difference it would have made for those individuals, if at all, any difference to start, a month later or 2 months later. So all we did is divide them out based on treatment under 12 months and over 12 months. We didn't break that out specifically by when they were treated during that time over 12 months.
Thank you. The next question is, what is brain myelination?
Oh, sorry. Brain myelination is the fat that forms around the neurons in the brain, and it's really important because it actually helps the neurons connect with one another in the brain and keeps them stable and growing normally. So it's an important process of development during childhood.
And what do you think of histidine?
I don't know what that is.
Okay. There you go. Maybe it was typed incorrectly. What ages should we start giving oils to our infants?
So typically I start the oils around 1 year of age because formula and breast milk tend to have these good things in them, and so you don't need to give extra in general as long as the baby's taking a good amount of, enough formula or breast milk to grow and develop. So typically I start them at 1 when we switch them over to cow's milk from formula or breast milk.
Is MCT oil better at night?
I have no idea. You can give MCT oil at any time of the day.
Is there ever a time you would not give growth hormone injections? For example, if a baby is sick?
So yes, but it's a hard question. There is absolutely no scientific evidence that there's a need to do that, to stop giving the growth hormone when the child is sick. However, I do ask parents to not give it when children are sick with a significant respiratory infection. So if they're really working hard to breathe or coughing a lot and can't clear their mucus, I ask parents just to hold the growth hormone for a few days while they're sick, just because we don't want to increase any factors that could make that worse. Growth hormone grows things, including the tonsils and adenoids. So you can imagine if you're sick with a stuffy nose and a cough with real thick mucus and your adenoids are bigger because you're on growth hormone, that can create a bad respiratory situation. So I ask parents usually I say if they're really sick, just don't give it for a couple days and then you can restart it when they're better. But there's no evidence to support that.
Is there a certain brand of probiotic that you would recommend, or should we just look for a certain strain?
So you want the ones that have the most cultures per whatever it says on the bottle. Like some of them will say like 1 million cultures per thing or whatever. You want the ones that have the most cultures because those are the ones that stand the best chance of some of it actually getting to the colon before being digested by the rest of the gut. So the more cultures, the better. And depending on your needs, depends on the probiotics. So for example, there is a specific probiotic that's good for constipation. It's called B-lactis. And so there are actually, I actually have a table that I went to a lecture on probiotics, and the woman talked about all these different things and which probiotics are best for each condition. So it really depends on your child's condition as to what's the best probiotic to use. I typically encourage people to talk to their GI doctor if they have one, because they're very familiar with these probiotics and can tell you for your specific child what would be the best one to try.
When do you think a person should start with probiotics?
So typically I start probiotics when phase 2A starts, so around 18 months to 3 years of age. When we start to see the what we think is the gut motility slowing down, so you start to see a lot of abdominal bloating after the individuals eat, that's when I usually will start the probiotics to sort of help move things along a little bit better. You can start them earlier though. There's certainly no harm in starting them at 1 or 15 months or whatever. You can start them whenever.
Is there ever a time a sleep study is warranted prior to starting growth hormone therapy?
So it's actually recommended, unfortunately by me, to do a sleep study on everyone before they start growth hormone therapy. The problem is that every infant with Prader-Willi syndrome actually has some degree of sleep disordered breathing on that sleep study. And there's nothing on that initial sleep study that would keep me from starting growth hormone, but there is stuff that I would want to treat at the same time I started growth hormone therapy. So for example, sometimes on a sleep study you can see evidence of gastroesophageal reflux. We know that's going to get worse when you first start growth hormone therapy, and so if we see that on that first sleep study, we know that we can treat it while we're starting the growth hormone so that it won't get worse. So we actually recommend that everyone have that first sleep study. The problem is that if the endocrinologist doesn't know Prader-Willi and know what to expect from a sleep study in Prader-Willi, they often use that as an excuse not to give the growth hormone, and so because they just don't know and they're concerned, about what effects the growth hormone would have on that. And so it becomes, sort of a double-edged sword. You kind of don't want to do it because if there's something abnormal, it may stop the doctor from prescribing the growth hormone. If your doctor's me, there's nothing that would stop them from prescribing the growth hormone. We just have to make sure we address whatever the issues are on the sleep study at the same time that we're starting the growth hormone.
Okay. Is there a better time of day to administer the supplements? As a parent of a 5-month-old, how do I determine when each of the supplements mentioned are appropriate yet?
So at 5 months of age, the only supplements that would really be appropriate are the coenzyme Q10 or maybe the carnitine. So coenzyme Q10 we use in the babies if they're having trouble staying awake to suck and swallow or having a lot of daytime sleepiness, and that you give in the morning. Carnitine is actually supplemented in formula, but it is not in breast milk. So if your baby is getting breast milk, you can start carnitine as early as you want. But if your baby's getting formula, you typically don't need it unless the baby's getting less than 22 ounces of formula a day. And so typically that happens when the babies are closer to 9 months of age and they're starting to eat real food. They start to drink less formula. But the carnitine also can help with energy levels as well as strength. So that's also given in the morning because it can be activating. The other supplements we typically don't start till at least a year of age, sometimes even older than that. Again, it's very individualized depending on the child and what they need. But I wouldn't start all these supplements on any baby other than possibly the coenzyme Q10 and the carnitine, depending on the individual situation.
Can we give NAC to babies and toddlers when sick, especially nasally and respiratory illnesses? How long does it take to work? Give it October to May or only when signs of illness?
So, NAC, so the question is because N-acetylcysteine, which we use for skin picking, actually loosens up mucus as well. So some people do it during illnesses to loosen up the mucus and help the babies get it out. To be honest with you, I've not ever given it to a baby, and I don't know that it's been studied in babies, but it could have been and I just don't know it. But I've personally never given it to a baby. The youngest I've ever given it is usually around 2 to 3 years of age to loosen up the mucus. I don't know if it's safe to give to a baby. I would definitely ask a pediatrician before trying it. And yes, if you're using it, you would use it through while your child has the illness, and then to loosen up the mucus, and then when the illness is done, you don't have to use it anymore. That one is not protective in the immune system. It just loosens things up a little bit so that you can cough them out.
What about things like Pediasure used to help with adding calories to an 18-month-old who is still in stage 1?
Say that again, Julie, I'm sorry.
Okay, what about things like Pediasure used to help with adding calories to an 18-month-old who is still in stage 1?
So my answer would be a big old no. and that mom should email me because Pediasure has a ton of sugar in it. We don't want to use Pediasure, and I hate Pediasure. I mean, sometimes we have to, but it's very rare. And so the only ones that really should still be on Pediasure at that age are ones that are exclusively G-tube fed, because that's a good G-tube source of nutrition. But taking it by mouth is terrible because it's got a lot of sugar in it. So we don't want kids to get used to the sweet taste of that.
Can CoQ10, I'm going to butcher this one, levocarotene and MCT oil all be given together?
Yes, you can give all of them together. A lot of parents just mix it in the yogurt or the oatmeal or whatever and give it all together.
Okay. Let me see. Is there an L-carnitine product recommended?
So I recommend the prescription one because you know exactly what's in there. The problem with a lot of the supplements is that they're not FDA regulated, so you don't know exactly what you're getting in each individual dose. So there is a prescription grade carnitine. Most of these supplements do not have a prescription grade, but this one does, and that's the formulation I recommend because you know exactly what you're giving your child with that one.
We're down to time for our last couple of questions. When a child is on growth hormone, how often is a sleep study required?
So usually I tell people that after you usually do one sleep study before and then a sleep study 6 to 12 weeks after starting growth hormone to make sure that things aren't getting worse with the growth hormone therapy. And as long as that second sleep study is normal, I tell people it's not necessary again unless the child starts having problems. So if the child starts snoring, starts having pauses in their breathing, starts waking up a lot during the night, starts having behavioral problems during the day, falling asleep more during the day, you've got to do a sleep study. But otherwise, as long as the second sleep study is okay, you don't really have to repeat it. But if it's not okay, then obviously you're going to repeat it based on what the sleep doctor tells you. Usually if it's not okay, they'll repeat in 6 months to see if it's getting better or not.
Are you concerned about the artificial sugars, for example, sucrose, Splenda, in CoQ10 liquid supplements?
Yeah, I hate artificial sugars. But the CoQ10 is used for a short period of time, typically just during infancy, and the sugar issues start to become more of a problem once kids enter phase 2A. And so I don't love it, but I'm not too worried about it since we're using it primarily in infants.
Okay, and our final question, what doses of CoQ10 and L-carnitine are recommended?
So typically for most babies, the dose of CoQ10 is 50 milligrams per day, 50 milligrams per day. For tiny little premature babies, we use 30 milligrams per day, and for bigger babies, we use 100 milligrams per day. And then for the L-carnitine, the dose is 50 milligrams per kilogram per day, so 50 milligrams per kilogram per day. And I typically give that whole dose in the morning. It can be activating, so it wakes you up. So a lot of doctors will divide the dose. I don't like to divide the dose because it can keep the kids awake at night.
Dr. Miller, we thank you so much for your time and all that you've provided to our families, and I will turn the presentation now over to Lori Moline for our final remarks.
Thank you.
Hi, I just want to say thank you to Julie also for all her help with facilitating the webinar series. She does an amazing job, and we are really appreciating her help tonight. And I want to give a huge thank you to Dr. Miller for her time tonight. We probably could have kept her here answering questions, into the wee hours of the morning. We just want to thank you, Dr. Miller, for being there for all of us and for our kids. We don't know what we'd do without you. You are our rock star, and we are so grateful to you for giving us this information. And I want to thank everyone who attended tonight's presentation. I hope you found it encouraging, got some of your questions answered. Dr. Miller mentioned you can always send her an email also. She is wonderful about
giving information through email, and that's another thing that we really appreciate. And remember, everyone who was a registered attendee will be getting an email within about the next 24 hours or so with a link to the recorded version of this presentation, so you can share it with family members, you can watch it again and make sure you get every detail. And this link that you get in your email will be active for approximately 1 month, so you have lots of time to watch it over and over and memorize it even. So anyway, thank you again for attending tonight, and this concludes tonight's presentation.
Thank you guys so much.
Good night. Thanks to everyone that attended.